Hey everybody, I'm Dr. Willardsen, and today I'd like to discuss a procedure that is one that I get a lot of questions from patients and also other doctors. And it's the question of immediate placement or immediacy, immediate placement of the implant. So do we pull the tooth, bone graft, let it heal? Do we pull the tooth, graft, place an implant? And then the third layer would be, do we pull the tooth, bone graft, place the implant, and immediately load the case or put the tooth on the implant? So I'd like to show a case today where we do just that, where the tooth had fractured at the gum line, so it's non-restorable. So we remove the tooth, the remaining roots of the tooth, and then prepare the osteotomy or the hole where the implant needs to go, graft around the defects that are there, and then prepare the final osteotomy via osteotomes, and then place the implant. So let's take a look at the video here. And so here we're using what we call a periotome, which is a small instrument to help elevate and extract the tooth, elevate the root and extract the tooth. It's very important when extracting the tooth that we protect, preserve, and maintain the bone. Because sometimes if teeth have had endo or a root canal, they can become ankylosed to the bone. It can be difficult to remove. So we want to try to preserve as much bone as we possibly can if we are considering doing an immediate placement. And so we can see here where we've elevated the root of the tooth out, and then you degranulate. You take a curette, clean up the alveolus or the extraction site, and then you start the process of preparing your osteotomy, or the hole where the implant goes. And in that process, you have to decide, because you're looking at a defect in the bone, and in this case it was a bifurcated bicuspid, and so you have to choose, am I going to go to the buccal or the lingual in my osteotomy? And so in this case I went slightly lingual because I want my access hole or the screw to be placed lingual. And so you can see here we've elevated the tooth out, and then I degranulate or clean up the extraction site. I haven't touched the tissue. I've not raised a flap. I have not used a scalpel at all, because I want to preserve the architecture of the tissue and the architecture of the bone. And so I keep all of these things in mind as I am thinking about the preparation or the initial preparation of the osteotomy. So I start, of course, with a pilot drill and then take an x-ray of that, make sure that my mesial distal location is right on, and then from there I can start the process of expanding the osteotomy and making it so that I can place this implant. I put the bone into place and start the initial osteotomy, graft the site, and then I step up to my next drill, which is a 2.0 millimeter pilot drill, starting with a Loma Linda drill at first to kind of get that pinpoint orientation. And then I use a 2.0 pilot drill, and then gradually increase the diameter of the osteotomy throughout the process. And so I'm preparing the osteotomy, and now I'm finalizing the osteotomy, and I have to determine, because I'm working with a NomoBioCare, the TI Ultra active implant, I need to determine the diameter of this osteotomy in order to get good fixation of the bone, in order to be able to fabricate a tooth or the provisional and immediately load it. So we've extracted the tooth, we've prepared the osteotomy, we've grafted the extraction site, and now we're placing our implant. And so you'll notice here that I'm getting 50 plus Newton centimeters of torque on this implant, so I'm completely fine to go ahead and start to, I can load the implant right away. And what that does is it helps to create the architecture of the soft tissue. When I make the provisional, I'm already starting to create the architecture of the soft tissue, so that when I do the final crown, you won't, a lay person or even some dentist would not be able to tell that this was an implant, because we've preserved as much of the architecture of the soft tissue and bone as we possibly could in order to get the most ideal aesthetic and functional result. And so once the implant is in place, then I start the process of fabricating and creating the emergence profile of the provisional prosthesis so that when I place it into the mouth, I'm able to create that architecture and maintain everything that the patient has lost. She's lost the tooth, the coronal aspect of the tooth, she's lost the root, and ultimately has lost the entire tooth. And so it's important for us to try to preserve, maintain the architecture and the emergence profile of that tooth, even though we're working with artificial materials. Implants are not teeth, but we do everything in our power to try to make it so that the implant looks just like the tooth. And so, you know, we're discussing today immediate placement, so extraction, bone graft, placement of the implant, and immediately loading and fabricating a provisional or a temporary on that implant. I'm Dr. John Willardsen, and thanks for watching.